I think now I have the pleasure of actually introducing Antoinette Hayes, the president of Regis College, who will introduce our speakers. And once she does do that and turns it over to Dr. Doonan, before I give it over to Dr. Doonan, I do want to put up one of our first poll questions. And President Hayes, you don't have to worry about that. All right? Okay, so now I can go to our first speaker. All right, and Dr. Hayes, you're on.
Okay. Good evening, everyone, and welcome to the President's Lecture Series on Health. Thank you for joining us for this timely conversation on the impact of federal administration on healthcare and public health. Healthcare in the United States, I believe, is under siege, with significant shifts in priorities, policies, and public debate. The decisions that have been made in Washington will shape everything from insurance coverage and public health funding to the regulation of pharmaceuticals, reproductive health, and the role of federal agencies in protecting the nation's health, all of which affect healthcare and public health at the federal and state levels. It is a great pleasure for me to say that the panel brings together a group of experts who will help us better understand what's happening, what may be coming next, and what these developments mean for patients, health professionals, and the broader health system. We will explore key policy changes, examine their potential implications, and discuss the challenges, but also the opportunities that face the healthcare community in this moment. So let's begin. Tonight, we have 4 prestigious speakers bringing their perspectives on the topic. Our first speaker is Dr. Michael Doonan, who's been with us many, many times. Thank you, Michael. A nationally respected health policy scholar and someone who has spent much of his career helping people understand how policy decisions translate into real-world health outcomes. Dr. Doonan is a professor and associate dean at my alma mater, the Heller School at Brandeis University, where he teaches national and state health policy and helps train the next generation of health policy leaders. Over the years, he has worked at the intersection of research and government, including time with the Centers for Medicare and Medicaid Services and contributing to national reform discussions during the Clinton administration. What makes Dr. Doonan particularly valuable for these conversations is his ability to step back and help us see how federal decisions ripple through states, health systems, and ultimately to the patient. We're very grateful that he could join us again to help set the stage for this discussion. Next, it is my pleasure to introduce Dr. Robbie Goldstein, the Commissioner of the Massachusetts Department of Public Health. In this role, Dr. Goldstein leads a department of more than 3,000 public health professionals, working across everything from infectious disease and environmental health to maternal and child health. His career has consistently combined clinical medicine, public health leadership, and policy work. Before becoming commissioner, he served as a senior policy advisor at the CDC and founded the Transgender Health Program at Massachusetts General Hospital, an initiative that has helped expand access to inclusive, evidence-based care. Dr. Goldstein brings a unique perspective on how public health systems respond to policy changes in real time, and we're delighted to have his insights with us this evening. Our third speaker is Carleen Pavlos. She has spent her career working to strengthen public health systems and ensure that communities have a real voice in shaping the policies that affect their health. Carleen is the executive director of the Massachusetts Public Health Alliance and previously spent nearly 2 decades at the Massachusetts Department of Public Health. During that time, she helped lead major initiatives in community health and prevention and was instrumental in establishing the state's Division of Violence and Injury Prevention. Her work has consistently focused on health equity and the idea that strong public health policy must be grounded in community experience and partnership. Charlene brings both deep policy expertise and a strong commitment to community-centered public health, and we're very fortunate to have her perspective tonight. Our fourth speaker is Colin Roosh, Director of Policy at Community Catalyst, a national organization known for its work advancing community-centered, consumer-centered healthcare policy. Colin leads national policy strategies aimed at strengthening the health system and improving access to care, particularly for populations who have historically faced barriers within the system. Over the course of his career, he has worked on major policy issues, including the Affordable Care Act, Medicaid, and the Children's Health Insurance Program. His work has focused on ensuring that health policy decisions are informed not just by economics or politics, but by the needs and experiences of patients and families. We are so pleased that he could join us as well to bring a national advocacy and policy perspective to tonight's discussion. What a thrill to have all four of you with us this night. Now I will turn the program over to Dr. Doonan. Dr. Doonan?
Okay.
Well, thank you, President Hayes. Thank you, Penny.
Okay.
Thank you, everyone, for
All right.
putting this
Okay,
event
thanks,
together.
And
Uh,
Dr. Doonan, hold on 1 minute. Okay, let me see if I can get you on my screen. I did want to, before you start, I wanted to be able to put up a poll question. And if I can do it correctly, it would be kind of fun to see what they have to say as participants. So I'm looking for where you are, but I will go ahead and pull up the poll and launch this one question. This is the only one I want to answer. Oh, no, let me go back. Okay. All right. So let me see if I can do this correctly. All right, I'm going to do this. All right, this is the question I'd like people to answer now. I hope you all can see it. The question is, which two areas of health policy under the current federal administration do you believe it had the greatest impact on patient care? And these are your four choices.
Dr.
And
Flynn,
I
the
can't
results.
tell. I can't
Sorry,
tell.
the results are up.
Are they?
That's
Oh,
what I see.
oh, all right. Now they're coming. This is good. Oh boy, everybody's having to answer all the questions at the same time, but that's okay. That's all right. I've learned something here. This is okay. I'll give people a little more time to answer this before Dr. Doonan starts. Okay, it's really important that the first question get answered. And yeah, you really aren't going to be able to answer the third question at this point. So we'll see what happens. All right, I've given it a lot of time. So I think what I'm going to do is end the poll and share the results. So With regards to Dr. Dunin's presentation, which two areas of health policy under the current federal administration do you believe have had the greatest impact on patient care? And it looks like the budget reconciliation and the NIH funding have won out, and we'll see once we hear what Dr. Dunin has to say. So I'm going to stop sharing here now. And I'm going to close this up, and I'm going to see if Dr. Dunin's right there, and I am going to turn it over to him now.
Wonderful. Thank you, Penny. President Hayes, thank you so much for that great introduction. I want to congratulate you on 15 years as president of Regis College, but more importantly for the trajectory that you put the college on, and the future that you've set it up for. Thank you. And you know what? We are so proud to consider you an alumni of the Heller School at Brandeis University.
Thank you. Thank you, Michael.
Pleasure. It's also a pleasure to be part of this panel. My fellow panelists are in the trenches every day, working on these issues. It'll be great to hear from them. What I want to do is set us all up. So I'm going to talk a little bit about generally about the American healthcare system and some of the challenges that we face nationally. And then I'm going to go specifically into what happened under the first Trump administration, how did things change with the Biden administration, and then what happened under the big beautiful bill, and what's happening with cuts in Medicaid, the Affordable Care Act, enhanced subsidies when they went away. How many people are going to be impacted by them? When are they going to be implemented, and what's going to be the effect? But I think President Hayes, you said something I think that's really important, and that the American healthcare system and democracy itself is at risk, and we all need to get involved. So how can we think about that going forward? I'm a political scientist, and what do political scientists study? Power, right? They're interested in who has power and how it's used, and in democracy and who shapes the rules and how the rules are shaped. Spoiler alert, states are incredibly important. Um, Commissioner Goldstein, your work every day is critical. It's critical to the nation. If democracy wanes nationally, it might be reignited by the states so that things can be saved. Okay, let me share my slides. Oh, that's a piece of Swiss cheese. Wait, what? What? The American healthcare system is like a piece of Swiss cheese. It's a non-system system where people get their health insurance from many places, and there are cracks where people can fall through the holes. Um, and these include private insurance, Medicare, Medicaid, CHIP, the Affordable Care Act, which provides subsidies up to 400% of the poverty level, expanded Medicaid, but not every state expanded Medicaid. Those are holes. Those are holes where people fall through the cracks. There are other public provisions of health care. Some people are uninsured. Other people pay out of pocket. It's a non-system system compared to other countries where there's one system where everyone gets coverage. The complications of the system, I know, as providers out there, nurses and other providers, you're having to deal with people with different types of insurance, and this is covered and this is not covered, and this has to have prior authorization. This is a real challenge for the healthcare system. Cost is another huge problem. You see that green dot up there? That's the United States. We are number one, baby. We spend the most than any other nation. Now, the line there, it suggests that as income goes up in a country, you're expected that you'll pay more for health insurance. So you should be on the line. The United States is not on the line. And estimates going forward, it's projected that by 2033, the United States will be spending $24,000 per person for healthcare. How does this compare with other nations? We are spending almost double what they spend in other nations. Now, that would be cool if we were getting our money's worth, if we had better health outcomes, if we lived longer than other nations. Well, how do we compare? Yeah, not so good. Here we are not number one in terms of life expectancy. We are the green line. And if we compare the other average OECD, more advanced countries, we can see that we're not doing so well. So we are paying the most, but we are not getting the most in terms of outcomes. Now, that's not all related to whether you have health insurance or not. Commissioner will tell us that a lot is about public health and social determinants of health and the link between poverty and opportunity and good health. But health insurance matters, and it matters a lot. People with health insurance and those without, if you hold everything else steady, the health outcomes, mortality, morbidity of people without insurance are much higher than those with insurance. So it's critically important. The good news here is that the Affordable Care Act worked to significantly reduce the number of uninsured in the United States. In fact, it cut it almost in half. Now, under Trump 1, there were a number of policies that impacted the Affordable Care Act, right? And during this time, politically, the House and the Senate were run by Republicans. They tried on a number of occasions to get rid of the Affordable Care Act. And it passed in the House of Representatives over 30 times. It took one vote. Senator John McCain went down in the well of the Senate and he put his thumb down. And that's the only thing that saved the Affordable Care Act. Now, the president can have power and do things without Congress fully repealing the act. And President Trump took a number of steps to reduce the effectiveness of the act. He repealed the individual mandate along with Congress. Um, they didn't actually repeal it. Guess what they did? They put the penalty to zero. So effectively gone. They ended cost sharing subsidies within the plans, right? They encouraged more cross state plans that didn't meet all the essential benefits. And in essence, to try to weaken the plan. They reduced the marketing money that was available for the plan. They limited the enrollment period and made it much shorter. And they provided state flexibility to do things like work requirements and to get rid of some of the essential benefits, right? And he chose not to defend it in court. So even though the president didn't change the laws, he used administrative power in order to weaken the Affordable Care Act. But it persisted. Now, under the Biden administration, he repaired and he significantly built on the Affordable Care Act. He expanded subsidies beyond that 400% of the poverty level up to much higher so that no one in the country would spend more than 8.5% of their income. And I've got a great chart to show the impact of this. He also signed legislation to get rid of surprise billing. That's if you end up in a hospital and your anesthesiologist is out of your plan, you can end up with a huge bill. That's another problem with the United States healthcare system is medical debt and people putting medical expenditures on credit cards so that they're paying high interest rates or being taken to collectors and being hounded for money that they don't have. All right, so what Biden did is he significantly increased subsidies and he increased the affordability. And guess what happened? The number of uninsured went down, right? He increased the outreach and enrollment. In other words, some of those things that Trump 1 did, he reversed them. He opened the enrollment period, put money in for marketing. And he also added a provision for prescription drug price negotiations. And that might be an area of bipartisan support and possibility that some additional work can be done there. All right, Trump 2. This is the official White House portrait of Trump for his second administration. And what did he do? A number of executive orders. Now, the rulemaking process is legislation. We all think about that, right? A legislation passes, but then what happens? Well, it goes to administrative agencies and they need to write the rule. Now, the rule has been considered the skin of legislation. It gives it substance, it gives it form. It's super important and often neglected. When President Obama wrote the rules for the Affordable Care Act, he did it in a progressive way, in a way looking towards increasing the number of the number of insured people in the country. The Trump administration through rulemaking, changed some of those rules and did some of the things that it did in Trump 1, reduce the enrollment period, reduce the marketing. But there were some other things that the Trump administration did too. They reorganized the executive. Doge, and a number of you voted for this in the poll, reduced NIH funding. It reduced the number of staffers and people working in the federal government that had expertise in things like insurance market reforms, right? A little brain drain in the federal government. States right now are preparing to make up for those federal cuts. But guess what? They can't do it. They can't do it all. The cuts are going to be too big. Enhanced subsidies and the Affordable Care Act, those tax credits, they were majorly reduced. Okay, this is the most important slide that I'm going to show you tonight. So I want everyone to work with me, okay? Do you see the blue line? The blue line right there? Now that shows the Affordable Care Act subsidies, right? And so if you look at the bottom there, that's income. And you say, all right, at 40% income, your subsidy works out to about 9.7% of your income, right? Now at 400% of poverty level or $51,000, you're paying 8.9% of your income. But what happens if you're making $1 over 400%? You get no subsidies and it equals what? 20% of your income, right? Is that affordable? Can you spend 20% of your income on health insurance? Didn't think so. So those were the subsidies. What happened under the Biden administration? That's the orange line, the pumpkin line. Everyone with me? So what happened during the COVID-19 relief law is that the Congress and the president signed and it said, you know what? No one can pay more than 8.5% of their income. So let's go back to that person with that $52,000 that was paying 20% of their income. Now they're just paying 8.5% of their income. And that's a huge subsidy. Has insurance become affordable for them? Yes, it has. So they can go into the marketplace and exchange and purchase insurance. But guess what happened on January 1st? We got rid of the orange line. We got rid of that line and we went back to the blue line. So what happened to that family that was paying 8.5%? They went up to 20%. So you remember, in the news at that time, you heard people that were paying like, 30 or 40 dollars a month, and their monthly premiums shot up to 300, 400 percent, or people that were paying 3 or 400 had it go up magnitudes higher. Well, those were the people. And so health insurance in the United States has gone back to having that cliff. It's become back to being unaffordable for many folks. Okay, people wanted to know about the big beautiful bill, or they thought that that had the most impact. And hey, I have to agree with the polling here, Penny. The audience was right. This is going to have a major impact on the number of uninsured. So what did it do? It included work requirements, and it said you have to work in order to get Medicaid services. It increased the eligibility redetermination to every 6 months as opposed to every 12 months. Now, these things don't sound so bad. What's wrong with them? Oh, actually, the impact of them are terrible. Why do I say that they're terrible? Because work requirements, most people meet the standard, but many people will be cut from the program because they cannot provide documentation. And this makes sense. If you're low income and you have 2 or 3 jobs, do you want to go to your employer and say, hey, I need documentation to show that I've worked this many hours over this time, and I've got to get that in? Oh my gosh. And the thing is, this has been tried in Arkansas and other places. And guess what what the data shows? It drops people off the rolls, but it drops people off who are eligible. So we're kicking people off of the Medicaid program who are actually eligible for the Medicaid program. Now, states like Massachusetts are taking pains to make sure that this doesn't hurt, but it's going to hurt. And there are estimates that a number of people who are eligible are going to be dropped for coverage. How well are they going to sleep at night? How well are they going to sleep when they find out that their kids no longer have insurance and maybe their daughter has diabetes, maybe their daughter has asthma, right? And they're dropped from the rolls, but they're actually eligible. And you can say, oh, shame on them. They need to get their paperwork in. Yeah, well, some of this stuff is to provide documentation that you're an American citizen. You could be an American citizen, but then you have to go get a birth certificate. Meanwhile, you're thinking about getting to work, getting the kids to daycare, and paying for your regular expenditures, right? And you've got to add this in. It's a barrier that's not necessary, and it's going to lead. And I'll show you the numbers. It's going to lead to a lot of people erroneously being dropped and going to the roles of the uninsured, right? Yeah, strict verification of your identity. Again, just like they're trying to change the voting rules, no, it's disproportionate low income vulnerable populations that have a harder time getting that documentation. Other big elements. Oops. Provider taxes. This is really complicated. And state direct payments. The takeaway message is states are going to have to put up more money for their Medicaid programs. Now, why is that a problem? They should just put up some more money. Well, you know what? The more we spend on Medicaid, the less we can spend on education, environmental protection, transportation, public safety, and a whole realm of things, right? The more, and it's really, really challenging because Medicaid is the fastest growing state budget, right? And it's what economists call opportunity cost. If we have to spend more on healthcare, even to cover fewer people, we're going to spend less on other things that are essential and that are really important. This is another thing that irks me tremendously about cost sharing. Um, so, in my health plan right now, I have a copayment of $25. So my youngest daughter, she has asthma, right? If she has an asthma attack, I take her to her primary care physician. It costs $25, right? For me, $25 is an appetizer and a couple of beers, right? I'm not thinking about that. Now, what if that $25, and here they can up it to $35. What if the $35 means bus fare? What if the $35 is a part of a food budget? Do we really want people to think about whether they should take their kid to get their asthma checked? Do we really want people to think about whether they should get their diabetes checked if they're having problems? No, 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 we don't. The evidence is really clear here, people. Having co-payments, it does reduce unnecessary care, but it also reduces necessary care, right? And it has a disproportionate impact. Even small dollar has a disproportionate impact on lower income populations. Do we really want them having to end up in the emergency room to get this care? That's going to be more expensive for all of us. There's also a number of provisions about non-citizens, even and immigrants, even legally documented immigrants will have a harder time, and Medicaid might not be available to them. Sometimes you hear rhetoric about undocumented immigrants using all these public services. They're on welfare cash assistance, they're on SNAP, they're on the Medicaid program. No, they are not. They are not eligible for these programs. They're still paying taxes, right, when they buy something in the store, but they're not getting these. They're not getting these services. And there's a ban on certain services in terms of transgender services. Something Commissioner Goldstein has dedicated a good portion of his life is serving these populations with necessary services that are going to be harder, essentially harder to provide. Yeah, people, I hate to say this, and you probably already know it, but we might have hit the high number in the percentage of insured in the United States. And that number is going to come down, right? It's estimated that 7.8 million will become uninsured because of the Medicaid changes, 4 million because of marketplace cuts, and another 4 million due to the enhanced tax credits. That's shifting from that orange line back up to that blue line. Those are lines, but they represent people. They represent people, the majority of whom are going to be uninsured. Oops. Uh, this just shows, and these slides will be shared with everyone, that the research shows that most people who are getting Medicaid are working the requisite number of hours. Either that or they're exempt. They're attending school, they have a documented disability, right? But many of them are going to have a difficult time documenting this, and they're going to end up in the roles of the uninsured. Even that shift I was saying from 12 months to 6 months, every re-enrollment period is a barrier. It's a barrier to getting care. I want to talk a few minutes about the Medicaid program because I think that
Dr. Doonan, I
yes.
just want to chime in here. You're at 21 minutes.
All right, I have
So,
2 minutes. Penny, can I have 2 minutes?
oh, you can have five.
Oh, okay, sweet. I will
Okay.
definitely end in 5. All right. Well, we are fighting for the very soul of the Medicaid program in this country. There, from one perspective, it's viewed as a welfare program. And in that case, you want it temporary. You want it focused on the needy, hard to get on, easy to get off. You want to protect public resources. You with me? Welfare program. Some states and some national politicians are viewing it that way. So we want these work requirements. We want these restrictions. Other states, and I would put Massachusetts in this category, view it as part of a social safety net. We can weave Medicaid and CHIP and Affordable Care Act and employer-sponsored insurance to get to universal coverage, right? It should be easy to get on, hard to get off. There should be easy exchanges into the next program. So if you're off Medicaid, you can get subsidized care. If you're not eligible for subsidized care, maybe you can get it through your employer. The policy preferences here are different for these models, right? The welfare program has all those things, work requirements, redeterminations, and we can see that in sort of what Trump did. And the solid safety net, we can see that in what Biden did, right? To make it easier to get on, to make it streamlined application. Okay? Does that make sense? Here, this slide just shows that incomes are going up very slow. They're at the bottom, and healthcare costs are going up very high. And this means access. If you can't afford it, you're not going to be able to get it, right? In Massachusetts as well. Um, yeah. James Madison, in one of the Federalist papers, he said that the accumulation of all power, legislative, executive, and judiciary, in the same hands, whether in one or many, hereditary, self-appointed, may be pronounced the very definition of tyranny. Concentrated legislative, executive power in one place is definition of tyranny. All right, what are our takeaway messages from our time together? Here, we have a non-system healthcare system with many holes and cracks. We've got a ping pong game going on between administrations who are visualizing things differently, like welfare, make it hard to get on, punitive, part of a universal healthcare system, right? We're fighting for the ideological soul for the country. At the same time, democratic institutions are really being, and this concentration of power is really being challenged. All right, what can we do? Well, it's been said that for evil to succeed, good people must simply do nothing, right? Edmund Burke said that the greatest mistake would be to do nothing because we can only do a little. And I can relate to this too, right? These problems are profound and there's so much to do. And if you can feel the full weight of that, you might just do nothing. But we can't do nothing. We all must do something in our own ways, engaging in the policy process. If you're a nurse, if you're a practitioner, engage in that policy. Tell people that the problems that you're having. Um, State actions matter, right? Could be the keepers of flames of democracy. And we all need to engage in the political process at whatever level we can. Um, I appreciate the extra few minutes here, Penny. I look forward to my fellow panelists and to answering questions later.
Now I'd like to introduce Dr. Robbie Goldstein. Robbie?
Thank you very much, President Hayes. Good evening, everyone. Thank you for having me here tonight, and thank you all for engaging on these really critical issues at such a pivotal moment for the Commonwealth and for the country. Unlike Professor Doonan, I don't have slides that I'm going to share with you, but I am hopeful that the words that I share can help translate for you what he shared into the real impacts that we're feeling in public health. Hope that they can take the slides and the images that he presented and turn them into the reality that we're facing every day. So, as we are seeing day in and day out, the Trump administration's actions from the outset and throughout the past year have profound consequences for the work we do protecting and promoting public health. That's true both here in Massachusetts and across the nation. So I'm going to talk about those impacts, but I want to begin with this, a simple statement. Public health in Massachusetts is strong. It's resilient. It's grounded in science. It is powered and nurtured by people in this Zoom room, people at the Department of Public Health, people in local public health, people across the Commonwealth, all of whom dedicate their lives to defending public health and protecting it. We are really fortunate to live in Massachusetts, where the Healey Driscoll administration continues to act decisively, urgently, unapologetically to protect the health, safety, and well-being of all residents. Our state is boldly grounding its decisions in evidence and data, and it's standing firmly with the people we serve. And that clarity of purpose matters because increasingly we're being called on to lead with science and stability at a moment when the federal landscape is defined by disruption and inconsistency and at times irresponsible decisions and actions that undermine the very foundations of public health. The first arena I want to touch on is funding, because so much of what happens in public health across the country relies on federal funding. And this has been one of the major sources of upheaval during this Trump administration. Funding is essential for public health. Funding isn't just dollars in a bank account. It's vaccines and arms. It's mental health services for a teenager in crisis. It's a community health worker knocking on a door. It's overdose prevention. It's disease surveillance. It is the infrastructure that enables vital programs and services to function. And over the past year, we've seen that infrastructure repeatedly destabilized. It began for us in early 2025 with the abrupt termination of $11 billion in critical public health grants to 23 states and Washington, D.C. That included 7 grants that had been previously awarded to Massachusetts, with outstanding funds totaling approximately $118 million. Those were funds that supported immunizations for children, mental health services, in-home supports for young adults, trauma-informed care. The programs were active, they were supportive, they were making a difference. Massachusetts responded by swiftly joining with other affected states to file suit challenging the terminations. But that, as we now know, was actually just the beginning. We have several more recent examples that also highlight the impacts of what start to feel like arbitrary funding decisions. In January of this year, the Substance Abuse and Mental Health Services Administration, known as SAMHSA, moved to cancel $1.9 billion in federal grants for substance use disorder and mental health programs across the country. That move would have terminated 4 awards to the department, totaling nearly $5 million, which supported critical harm reduction, substance use, and suicide prevention services. Less than 1 day later, the funding was reinstated. No explanation, no clarity, no acknowledgement of the disruption that the action caused. Similarly, in late January, Federal Health and Human Services notified public health departments across the country on a Saturday morning that the Centers for Disease Control and Prevention's Public Health Infrastructure Grant Program, or FIG, had been paused. These grants funded all 50 state health departments, as well as Washington, D.C., 8 territories, and 48 large localities across the nation. They represented $5 billion that departments rely on to function. Hours later that day, the pause was reversed. I want to be completely clear. The reversal of these cuts was good news. It was great and welcome news. But the uncertainty, confusion, the panic caused by these federal actions and announcements takes a significant toll. It creates fear for our staff and for the public health workforce across the country. People worry about their jobs, their families, their livelihoods. It diverts time and energy away from the work that matters most, which is serving individuals and communities. Public health depends on stability, and that stability is being tested like never before. But I want to reiterate that here in Massachusetts, we're standing on strong ground. Because in the face of these challenges, we have substantial state funding to protect public health, more than most other states, even those that are much larger than us. And this foundation remains unshakable, and it matters. It really matters now more than ever. Beyond funding, we are seeing significant impacts on policy and communications. Before we even began to see major policy changes, we started to see changes to federal websites, including the quiet erosion of trusted and important information from the CDC website. Content was removed, including information on HIV prevention, contraception, and adolescent mental health. Some of what had been initially taken down has been restored, but there remain major information gaps. And I think what's even more troubling is that people now question whether they can trust the information being offered on federal websites. Is it complete? Is it science? Is it ideology? At a time when misinformation and disinformation are already major threats to public health, these changes have made all of our jobs that much harder because public health runs on trust. Trust on data, trust in institutions, trust in those who deliver and support care. And when that trust is weakened, everything becomes more difficult. So we have to speak out when science is misrepresented, when the federal administration casts doubt on things that have been established by an overwhelming body of scientific research. We can't just stay quiet when the federal government makes a false declaration about the danger of using Tylenol while pregnant. We can't allow misinformation about a link between vaccines and autism go unchallenged. That is settled science. We have to create or continue to build out our own resources, collaborating with other states and organizations to preserve access and to protect the integrity of vital information. One of my priorities as commissioner has been to modernize our data systems. And part of that is increasing public access to the wealth of data about the health of Massachusetts residents and communities that we have at DPH. We created an online DPH data library just for that. In contrast to the federal government, we're leaning into transparency, to data availability, to shining a light on the truth rather than obscuring it with the darkness of mis and disinformation. On the policy side of things, we've seen significant changes across the federal agencies that we have long relied upon. That includes Health and Human Services, Centers for Disease Control and Prevention, and the Food and Drug Administration. The changing landscape is reshaping how public health operates in this country. And much of this comes into sharp focus around vaccines. For decades, vaccine policy in the United States has followed a clear and consistent and trusted model that has been grounded in science, guided by independent experts, and communicated transparently to the public. And that model has been disrupted. One of the most radical actions we've seen during the current federal administration is on vaccine infrastructure. As you know, during the past year, we've experienced a steady and continuous dismantling of longstanding advisory processes. We've seen inconsistent federal messaging. We've seen decisions that introduce uncertainty into systems that depend on clarity and trust. Last year, HHS Secretary Robert F. Kennedy Jr. fired all members of the Advisory Committee on Immunization Practices, known as ACIP. He appointed all new members, few of whom had vaccine knowledge and expertise, and many of them people who share his anti-vaccine ideology. A series of deeply concerning changes and recommendations have come out of the newly reconstituted committee. In the face of this, we've worked as part of the administration to build a state vaccine advisory infrastructure rooted in science. We developed the systems and the processes that are needed to launch a statewide, state-run vaccine program quickly. I issued a statewide standing order enabling pharmacists to dispense and administer COVID vaccine. The following month, at Governor Healy's direction, we worked with the Division of Insurance and issued a bulletin requiring Massachusetts insurers to continue covering vaccines recommended by the department. Massachusetts became the first state in the nation to guarantee insurance coverage for state-recommended vaccines. In December, Governor Healy joined me to speak out against federal misinformation about vaccines and autism. At a forum on strengthening trust in childhood vaccines, we reaffirmed the importance of hepatitis B vaccination for newborns, and we brought together pediatric providers, community partners, and state leaders to discuss strategies for supporting childhood vaccination and countering misinformation coming from the Trump administration. And this year, we issued our own evidence-based childhood immunization recommendations. Rather than adopting the reckless changes issued by CDC, we aligned with the full routine pediatric vaccination schedule endorsed by the American Academy of Pediatrics. Importantly, we didn't do this alone. In September, we formally announced our partnership with several other Northeastern states and New York City to form the Northeast Public Health Collaborative. Through this group, which has expanded to include states from Maine to Virginia,
now you
and several
screen.
major urban health departments in between. We share expertise, we improve coordination, we enhance capacity, we strengthen regional readiness, and we promote and protect evidence-based public health. But while people in Massachusetts and in other states that have taken similar actions had the reassurance that they could maintain access to vaccines, many people across the country are not as lucky. And that's why a Massachusetts federal court ruling a few days ago matters so much. I am sure you're going to hear about this from Carlene Pavlos later tonight. A federal judge temporarily halted changes to the CDC's vaccine advisory process, finding that the process used did not meet long-established legal standards, including requirements for scientific review, transparency, and balanced expertise. As a result, ACIP cannot move forward in its current form. It canceled a meeting that was scheduled for this week. For those of us in public health, the ruling brings a sense of relief. It reinforces something fundamental. It tells us that how decisions are made, not just what decisions are made, matters deeply for the health of public. It's good news, but we cannot let our guard down or claim victory for vaccines. It's a temporary ruling, it's likely to be challenged, and the underlying challenges have not gone away. The uncertainty that clinicians, patients, and public health leaders face is still very real. This moment matters, but it is not the end of the story. Well, over the past few decades, we've made progress in areas like expanding access to reproductive care, advancing HIV prevention and treatment, reducing overdose deaths through harm reduction, and expanding access to care for LGBTQ communities. We also have to recognize that these gains are not guaranteed. So as I mentioned, the policy shifts we're seeing combined with the instability, the whiplash of funding and of messaging threatens our progress. When funding for harm reduction is cut, overdose deaths rise. When access to reproductive care is restricted, health outcomes worsen. When trust in vaccines erode, preventable diseases return. The burden does not fall evenly. It hits hardest on communities that are already marginalized, disadvantaged, and underserved. That includes low-income communities, communities of color, immigrants, rural communities, and LGBTQ individuals. Health equity is not just a goal. It is a fundamental principle that guides our actions and decisions. It's about providing everyone with the opportunity to attain their highest level of health, regardless of race, ethnicity, socioeconomic status, or zip code. We know that health disparities exist in our communities, and they have profound impacts on individuals, families, and our society as a whole. These disparities are not random. They are not unavoidable. They are the result of systemic injustices and inequities that we must address. And that's why, for me, it's deeply disheartening to see federal grants, which for years have supported programs that lift up health equity and expand opportunity, that those grants are now placed at risk or reshaped in ways that discourage even naming disparities or including the letters DEI in grant applications. That shift does not just change the language. It threatens the very strategies that have helped us reach communities too often left behind. Focusing on health equity is how we improve health outcomes for everyone and how we build a more just and equitable society. It means addressing the social determinants of health, access to care, education, safe housing, and stable employment, all of which shape whether people have a fair and real chance to be healthy. The work of health equity is the work of public health. We cannot and we will not back away from it. All of this means that we are at a moment of real challenge. But this is also a moment of real responsibility because public health has always been about more than systems, programs, and policies. It has always been about people. Public health is whether a child gets vaccinated, whether a person struggling with addiction finds support, whether a family can access care when needed. And in moments like this, the role of public health becomes more important than ever. We have to be clear-eyed, steady, and we have to continue to lead with science, compassion, and integrity. Even in the face of uncertainty, especially in the face of uncertainty, people and communities are counting on us. And here in Massachusetts, I assure you, we will continue to meet that responsibility. So thank you for giving me some time, and I look forward to the discussion later tonight.
Thank you, Robbie. And now I'd like to ask Carleen Pavlos to get started. Carleen?
Thanks so much, President Hayes. And thank you to Regis for hosting this event tonight. I am just so honored to be on a panel with these amazing leaders. You're going to hear from me some very similar framing and concepts to what you have heard from Dr. Doonan and Dr. Goldstein. But with a different twist. I'm going to be, I hope, talking about the ways in which, as Dr. Doonan said, you can engage at whatever level to take action to continue Massachusetts leadership in the public health space. And so with that, I do have slides and I'm going to share them now if I can figure out, there we go, how to do that. Okay. I hope right now that people are able to see my slides. If you can't, would somebody give me a signal?
If I can see them, everybody can see them.
Wonderful. I'm so glad. Okay. So again, I'm Carleen Pavlos from the Massachusetts Public Health Alliance, and I'm going to be talking about the work that the MPHA, the Massachusetts Public Health Alliance, does. We are a very small 7-person nonprofit organization that works to create a healthy, equitable, and just Massachusetts. It's a hard time to be doing that right now, as you have just been hearing, both from the policy perspective and the policy implementation perspective. There is a lot happening right now at the federal level that is putting pressure on anybody that is working towards a healthy, equitable state. But at MPHA, we're doing it in a way that feels so hopeful and promising because we are doing it in community, in alliance with partners. And I'm going to talk a little bit more about why that's so critical, because the space that exists between that vision that we have and the current context really does need to be filled by action. But the action has to be not just scattershot. It has to be intentional, and it has to focus on what matters to make change towards that vision. And it needs to be done in a way that builds community power. Dr. Dunan talked about the importance of power, and we at MPHA really believe in community power as what moves the needle to create greater equity, even in the face of the federal actions that are happening right now. So I want to talk just a little bit more. These framings have already been brought up, but I want to just do a baseline check about what makes us healthy. We've been talking a lot about the health care environment that exists and what federal resources are doing to damage the already Swiss cheese healthcare environment that we live in. But what makes us actually healthy, what really influences our health outcomes, are the social and economic factors and the health behaviors that those allow us to engage in, right? Those things that we call the social determinants of health. So it is the social determinants of health, social and economic factors, the physical environment, that MPHA really focuses our attention for action and our policy work on. And again, I want to talk just briefly about the importance of doing that in a way that builds community power. At MPHA, we believe profoundly and deeply that people who experience health inequities have been left out, pushed out actually, of the policy-making process that impacts their lives, that creates the inequities that they are experiencing. And so working with and through community coalitions and building community voice and power is precisely the strategy to change all of that. And so we do a lot of convening coalitions, bringing people to the table. We do what we call solidarity organizing, which is identifying community-based coalitions that already exist and getting behind the solutions that they've already identified and putting our expertise in how to shift policy behind those community identified solutions. And then we also do a lot of capacity building. We do training and professional development and consultation with organizations that want to build their capacity to make change in the policy setting. And again, we do all of this because power is a social determinant of health. As we build community power in and of itself, that is decreasing health inequity, and it is building the muscles that are needed to make communities more cohesive and healthier. So the whole title of this evening tonight is on pushing back against the federal government. And at MPHA, we're thinking of that in terms of pushing back in order to keep moving forward. And there are opportunities to do all of this, both at the federal level and at the state level. And I'm going to talk about those. I'm going to give you some very specific actions so that you can engage with us. But as a reminder, they are going to be actions that address those structural barriers, the social determinants of health that we were talking about, and actions that actually follow the lead of people who are being impacted right now. So these are not things that are thought up at a think tank. These are, by and large, actions that are being recommended by community and by community-based organizations and community residents. Okay, so let's focus first on Massachusetts. Commissioner Goldstein talked about the impact of the federal government on the budget of the State Department of Public Health and also on the Medicaid budget. We heard much more about that from Dr. Dunan. In Massachusetts, like states across the country, our state government is faced with a quandary of how to respond to that, those cuts, those dreadful and deep federal cuts and how to respond to that as they build the budget, our state budget, that will be put in place on July 1. So we are part of a coalition with being organized by an organization called Raise Up Massachusetts that is focusing on stopping the cuts through a number of different strategies. One of them is to reject the corporate tax cuts that are part of the One Big Beautiful Bill, which is, of course, not but a terrible bill. States do not have to automatically adopt the cuts, the corporate tax cuts that are part of One Big Beautiful Bill, and we don't have to adopt those here in Massachusetts. We are also, as part of this campaign, focused on passing something known as corporate fair share. Now, this sounds like perhaps boring tax policy, but I'm going to tell you right now that paying attention to this one issue where giant mega corporations, global corporations, generate profits in the United States and then put them in offshore tax havens. Massachusetts taxes those profits at 5%. All the other New England states tax those profits at between 50 and 60%. There's legislation pending right now in our state legislature called corporate fair share that would change that and generate hundreds of millions of dollars that could be used in next year's budget to help plug some of the holes that the federal government is creating. Finally, as part of this campaign, we are advocating with the legislature to tap the state's rainy day fund. We have an $8.6 billion rainy day fund. Now, even something that large is not big enough to completely offset the federal cuts. But by tapping some of what is in that rainy day fund, we can minimize the worst damage that is coming to our state if, in fact, we don't put in place some of these strategies to minimize the damage that the federal government is causing. So, and I should have said earlier, but I'm going to put links at the end of my remarks. I'm going to put links for all of these into the chat so that you'll have a chance to connect online with some of these organizations that are leading this work. The second thing I want to raise is responding to the housing crisis in Massachusetts. Obviously, if you live in an unstable home environment, you can't be healthy. If you're homeless, you certainly can't be healthy. And there are lots of studies that connect unstable living environments with poor health outcomes. So we work with a statewide coalition known as Homes for All Massachusetts to respond to this housing crisis by focusing specifically on things that protect renters, that protect tenants, and help keep them in their own homes. The major focus right now is on rent control in Massachusetts. Right now, rent control is illegal in Massachusetts. No city and town across the Commonwealth is allowed to implement rent control. So we are taking that issue to the ballot. To get it on the ballot, the campaign, a totally unpaid volunteer network across the Commonwealth of Massachusetts, collected more than 120,000 signatures to get rent control on the ballot next fall. We are working hard. While there is legislation moving through the state legislature to try to pass this even before next fall, if it doesn't pass, and it's unlikely to, given the number of legislators in the state legislature that are landlords. So given that, we're taking it to the ballot, and it will be one of the, it helps create a cap of 5% increases on rent, which protects communities. It protects people and allows them to continue to live in the communities that they have helped to build. And finally, one of the other priorities that we are talking about consistently at the Massachusetts Public Health Alliance, because it has such a significant impact on our friends and neighbors, is the federal abductions of people that are perceived as immigrants. we've seen them across the country, and they have been happening here in Massachusetts as well. So we are part of the Massachusetts Immigrant and Refugee Advocacy Coalition, or MIRA, Coalition's Protecting Massachusetts Communities campaigns, which focuses on making certain that local police departments don't become tools of ICE, and that Massachusetts also has a funding mechanism to support immigrants who are facing detention and deportation. So very much like having a right to an attorney when you've been accused of a crime, this would create a fund that would provide you with an attorney if you were facing detention or deportation. Again, I will put links to all of these campaigns into the chat when I'm finished. I want to also highlight work that can be done at the federal level. Commissioner Goldstein talked a little bit about this. Our basic public health protections are being undermined daily by Robert F. Kennedy Jr., the Secretary of Health and Human Services, undermining vaccines, undermining strategies for harm reduction, undermining Medicaid and the exchanges, undermining the very idea of peer-reviewed, transparent science as what guides our public health strategies and actions. So that lawsuit that Commissioner Goldstein spoke about against RFK on vaccine policy, Massachusetts Public Health Alliance is one of the plaintiffs in that case. We joined with the American Public Health Association, the American Academy of Pediatrics, the Infectious Disease Society of America, the Society of Maternal and Fetal Medicine, and others to sue RFK and Health and Human Services on their vaccine policy, beginning with a change that was made last May on removing pregnant women and children from the COVID vaccine recommendation, continuing with the firing of the ACIP members that Commissioner Goldstein referred to, the Advisory Committee on Immunization Practice members, the appointment of unqualified members, continuing with the removal of the hepatitis B vaccine from the birth dose from the recommendations, and then continuing all the way through a pediatric vaccination schedule that was released in January, removing 7 vaccines from the schedule without any evidence. And just this week, on Monday, the order came down, as the commissioner referred to this order, staying the January childhood immunization schedule, staying the appointments of the ACIP members, and staying all votes that had been taken by ACIP since it was reconstituted. So it is, as the commissioner said, it's a huge victory for public health, for science-based policymaking, and for those of us who believe that the federal government's power must be checked. There have to be checks and balances on the federal government's power, although, of course, this administration has made it clear multiple times that they do not believe that their power is unchecked. They believe, and actually their attorney said in federal court, that their power was unfettered and unreviewable. Those were his words. So this is a huge victory. It is likely we're at sort of halftime. This is not the end of the game yet. But we and the other members in the suit are continuing and are feeling, at least this week, we're going to feel pretty good about this, because it is a demonstration that when we organize and fight, we can win. So it's making us feel like we're seeing the arc of history and the bending towards justice. But we do have to be real tonight, that we face enormous challenges. I've talked about some of the things, the commissioner has talked about some of these things, Dr. Doonan has talked about some of these things, but we face not only the challenges that we've mentioned tonight, but challenges, these public health crises of climate collapse, of food access, the spiraling costs we've talked about, the loss of trust in public health, and very importantly, in the context of a federal administration that is bent on not just challenging, um, not just making challenging decisions, but on intentionally deepening inequities, intentionally sowing fear and chaos so that we can't, so that we're less likely to be able to effectively organize and push back. But there is hope. We have it. The right future is possible. It's just not inevitable. We have to return to this idea that power is a social determinant of health and remind ourselves that it is collective action, and building collective action for this power is important. So here's my last slide. I'm hoping that you do get involved. Click on this QR code and join MPHA. You can sign up using this QR code. You can sign up for our newsletters and our action alerts and learn exactly how you can participate in some of the work that I've been talking about tonight. So with that, I will stop the share and thank you for your attention.
Thank you so much, Charlene. It was really lovely and pulling things all together. I mean, all three of you so far, it's just been amazing. And so now I'd like to bring forward Colin Roosh, Director of Policy at Community Catalyst. Colin?
Thank you. And I'll just say, these are some hard acts to follow. Some really great and powerful presentations so far. For those of you not familiar with my organization, Community Catalyst, we are a national nonprofit healthcare advocacy organization, and we are committed to the mission of creating a healthcare system that is rooted in race equity and justice, so that everybody gets the care that they need. I feel pretty good about my summary slides here. I was asked to sort of start with a recap of my fellow presenters' key points, and I attempted to do that absent seeing or hearing their talking points in advance. So I'll quickly walk through some of the key policy changes that have been discussed so far, that we're concerned about under this administration and Congress, as well as what we know to be the impacts of those policies, or what we can reasonably assume will be the impacts of those policies. So, Dr. Doonan outlined a number of the cuts and increases in costs that we are currently seeing or about to see across health coverage programs, both private and public insurance. And so, what we're now immediately seeing as a result of the ACA's premium tax credits sort of going back to those pre-COVID era rates are that people are seeing skyrocketing premiums and higher out-of-pocket costs. That means many people are signing up for lower value plans with higher deductibles and higher out-of-pocket costs. And on top of that, the administration is attempting to roll out new rulemaking that would increase those out-of-pocket costs even further and really lean into junk insurance products that don't cover the services that most people need and leave them with considerably higher costs for the healthcare services that they do need. And all of this is occurring at the same time that we're seeing huge cuts to state Medicaid budgets. I believe, I'm not going to get into the ins and outs of all the policies that are impacting state Medicaid budgets, like provider taxes that Dr. Doonan mentioned, but it's estimated that Massachusetts alone over the next 10 years is looking at losing about $17 billion as a result of the Medicaid cuts in the One Big Beautiful Bill Act. So that means not only, huge coverage losses, more uninsured people, but also more people with medical debt, more uncompensated care, and likely means that states are going to be faced with hard decisions about cutting what benefits are covered in programs like Medicaid, and also other publicly funded programs and initiatives across the states. I wanted to mention one thing that I don't think was specifically addressed yet, but that's, the impact of this administration and Congress's policies on the healthcare workforce and the educational pipeline. So one of the provisions in the One Big Beautiful Bill Act was changes to student loans and placing limits on how much people can borrow in order to attend a higher education. But they've also made changes to what are considered professional degrees, and therefore how much people can borrow in order to go to medical school, go to nursing school, for example. I mean, what that really means is fewer educational opportunities, particularly for less well-resourced communities. It also means, a greater strain on higher educational institutions that, rely on the ability of their students to have financial support to attend. But it also means a less representative workforce. This will disproportionately impact low-income communities and communities of color. And I think it's safe to say that what we need in this country is not only a larger and more robust healthcare workforce, but a healthcare workforce that actually better represents the people that it's serving, especially in communities that currently lack access to healthcare providers. For example, the dental care workforce is overwhelmingly white, and yet we know that when we look at the Medicaid program, white dentists are much less likely to participate in that program than their non-white counterparts, and yet we're not creating a pipeline of healthcare professionals that actually, looks like or is culturally representative of the people that it's serving and the people that need care most. Um, on the healthcare institution side, cuts to provider taxes, limits on how states can direct payments to high value and high need services, and an anticipated increase in uncompensated care will all have pretty severe implications for rural and safety net hospitals and clinics, many of which are already at risk for closure. It will mean greater access barriers in rural communities and underserved communities. And, it may mean, fewer jobs in those communities. Oftentimes, hospitals and healthcare systems are the largest employers in small communities, and that means a huge hit to those local economies. Um, others, including Commissioner Goldstein, have spoken to, the weakening of our public health infrastructure, whether that's vaccines or the recommendations by advisory bodies like ACIP, that, underpin, what must be covered at no cost. Preventive services are largely free thanks to the Affordable Care Act, but that relies on recommendations from bodies like ACIP and the U.S. Preventive Services Task Force. And we've seen this administration, fully gutting and overhauling those entities while also blocking professional associations like the AMA or the American Academy of Pediatrics from participating in that. And at the same time, we're seeing huge cuts to federal grants and public health programs. Commissioner Goldstein mentioned sort of the wild swing that we saw in attempts to cut SAMHSA funding, which provides money to states and communities to address substance use disorder prevention, treatment, and harm reduction programs. And so what all this means is not only, greater public confusion, and, barriers for providers in attempting to, provide the care to their patients and get that care reimbursed by insurance. But it also might mean that many people's insurance no longer covers the services that they need, especially, preventive services like certain vaccines. And all of that means, worsening health outcomes and a disproportionate impact on marginalized communities. Carlene, honed in on the harmful and shameful immigration enforcement that we're seeing right now. On top of that, this administration and Congress have made changes to immigrant communities' eligibility for healthcare programs like Medicaid, their eligibility for premium tax credits in the marketplaces, and I think it was Commissioner Goldstein who noted that that's not just really about undocumented immigrants. In fact, uh, undocumented immigrants have not been eligible for these programs to date. Instead, what we're seeing is tearing away access to health coverage for people who have come here as refugees, as asylum seekers, victims of domestic abuse and human trafficking. And so, this is really a targeted set of policies aimed really at the most marginalized in our country. In addition to that, we've seen a lot of policies targeting trans youth and the LGBTQ community, including eliminating the availability of federal dollars to flow through programs like Medicaid or even some other insurance programs like TRICARE that military families are eligible for gender affirming care. We've seen cuts to family planning and abortion services, and we've also seen significant changes to um, the definition of sex, for example, the elimination of gender traits from public programs and insurance programs. And I just really want to underscore that like this is this feels like an effort to erase people. But just by not documenting people doesn't mean that they don't exist. It means that we are less able to attend to their needs and to the needs of the communities that they live in. So, that means we'll have more people left with no avenue for affordable healthcare coverage whatsoever. These immigration enforcement efforts are also having a huge chilling effect on people's access to coverage. So even when, families of mixed immigration status are, eligible for public coverage, they may be less inclined to seek care for fear of, encountering ICE in the clinic or in the parking lot. And all of this means a strain on safety net clinics that serve those communities. It also means, in the long run, worsening mental health, maternal health, and infant health. Um, a number of folks spoke to the weakening of, data and research in this country as a result of this administration's policies. We've seen the elimination of important data across federal websites, including the CDC and CMS. We've seen huge cuts to publicly funded research. And that means that we're not only less able to conduct good research and drive innovation, but it also means we have fewer indicators of disease prevalence, of health outcomes, of early warning signs for the next pandemic, um, and a real strain on research institutions. So, before I dive into my thoughts on what we can do, I want to underscore what Dr. Doonan and Carlene both spoke to, which is power and the power of communities and the power of individual people. And the fact that many of these policies, I believe are really systematically designed to reduce the power of marginalized individuals and communities who already have the least power in our country. And so, that means it's all the more important that the rest of us do more to elevate their voices, to elevate the impact of these policies. And I'll start with, holding federal policymakers and state policymakers accountable. This is an administration and, many members of Congress who ran on and continue to speak to the importance of affordability while at the same time completely undermining affordability. Um, Now, I'll also say that, you know, I am not always the right messenger for a given policymaker, and you may not be the right messenger for a given policymaker. But we have allies, and it's a matter of, not only engaging with impacted communities, elevating their voice, engaging them in the policymaking and political processes, but also finding, influential messengers, who, to whom policymakers will be more receptive. That might be hospital administrators, it might be governors, it might be healthcare providers in your community, all of whom can speak to the health and economic impacts that these policies are having. Um, and to that end, I think it's important that we ensure that healthcare is central to the broader conversation that's happening in our country right now on affordability. Yes, people are rightfully concerned with the cost of groceries, gas, and housing. But we also need to make sure that healthcare is not left behind in that conversation. My organization did some polling about a year ago, before the One Big Beautiful Bill Act was passed, and we found that more than half of voters across the political spectrum cited either an inability to afford the healthcare that they need or major concerns with their ability to afford healthcare and health insurance for their families. Certainly, those concerns are considerably higher these days. Um, and I also think really leaning into shared values is important. I think we often discount folks who may have voted for this administration as not interested in pushing back. But our polling also found some really surprising things, which is, 80% of people want the government to be playing a stronger role in lowering healthcare costs. 70% of people would prefer a healthcare system that ensures access to care in all communities. 73% of people believe that healthcare should be treated as a public good. And the list goes on, but I think it's really important to consider the fact that, when we dig into these specific questions and issues around access and affordability of healthcare, we have quite a bit in common across the political spectrum. And so it becomes a matter of, you know, at the community level, having these conversations, and encouraging everyone to engage, with their elected officials, with their state policymakers and their federal policymakers. And I think that includes providers, small businesses, and really honing in on both the health impacts, but also the broader economic impacts that these policies are having on communities. So as we're thinking about civic engagement, it's important to combine individual and community level stories and voice with sort of the wonkier, policy considerations and impact as we make a case for change, for reversing some of these harmful policies, and moving, even further into the future towards a healthcare system that really looks less like Swiss cheese, and perhaps more like a craft single. I don't know. Um, I'll say a couple other things. I was asked to speak to what, academics might be able to do in this moment. Um, I think, we need research, and, I recognize that it is harder than ever to conduct that research, but as these policies are rolled out and implemented, it will be incredibly important to understand the impact that they are having on um, health, on economic well-being, on employment, on community economics. The list goes on. And as we're thinking about how to engage in the policy process, we heard Commissioner Goldstein and Carlene both speak to some significant wins in terms of legal challenges to some of these policies. But in order to get there, we also have to create a public record, challenging these policies, outlining where they are not relying on evidence, where they are inconsistent with statute, and where they might be illegal. Because oftentimes those legal fights are protracted, but having that public record, commenting on regulations, for example, helps build the case for those wins down the road. And I will stop there. I believe my slides will also be available for folks, and looking forward to the Q&A.